maintain a potential between the cell membrane and the extracellular fluid, okay? And that's kind of its whole thing. And one of its more important things that it's focused on is it keeps the potassium level where it should be. Magnesium is mainly absorbed in the small bowel and excreted in kidneys. So that's essentially how you get it, how you lose it. So, and when it talks about magnesium being, so when you go down into the kidneys here again, you remember that the loop of Henle when the potassium would come out and all these things would come out? Well, without magnesium, that's not going to happen. Which means the potassium is going to continue through, not leave, go out to the end, and you end up getting rid of it. So you're going to lower your potassium. So with that in mind, just think about it. If you give a patient with a low magnesium, if you give them potassium, are they going to be able to, is it going to fix anything? No. You're going to put it in, it's going to come out. So you got to fix the magnesium level before you fix the potassium level, because those two go hand in hand in that way. That's why that's so structured with potassium. But it's true for sodium, it's true for all of them, but mainly potassium is one of the big ones. Hypomagnesemia, low levels, and that's associated with hyponatremia, hypocalcemia, and hypophosphatemia, but also hypopotassium. That was not over for some reason. Yeah. And all these get knocked out for the same reason that I just told you. That little force thing in the loop of Henle is not over. So it doesn't leave, it just continues to leave, ends up leaving. Of course, it can, if you don't have it, you end up with hyperreflexia, ataxia. Ataxia is when you lose body control. I always forget, what's the one for the bleeding nose? It's really close. Ataxia is loss of movement, and for the bleeding nose, it's like something else. You end up doing convulsions and even death in extreme cases. All these electrolytes are very, very important. Hypomagnesemia-induced cardiac dysrhythmias originated with ventricles. And this, again, probably has more to do with the potassium. Hypertension and hypomagnesemia patients can be difficult to control. They lose mobility in their GI muscles and is clinically manifested as dysphagia. But you know, if they run a lab test, it would tell you, what is their magnesium level. What's dysphagia? Man, you guys are awesome. That's exactly right.
At rehab, we have to take a little training class on, because the patients will get autonomic dysreflexia with their spinal cord injuries.
Yeah. I know they come up, the speech therapists can go in there too, see if they can swallow and stuff like that. That seems like
they
such a,
do swallow this.
that seems so dangerous to me. Here, swallow this, good luck.
The autonomic dysreflexia, like if they have too much, like, their body, like, if something is off in their body, like like something is like poking into their leg, like, because they're like, have like a severance somewhere in their spinal cord, the brain can't like figure out what's happening, that connection is, so then it like freaks out, and then their blood pressure will start to like spike up, they start to sweat, they like, all this stuff happens. So you think they're like pre-coding, but really it's just like either you gotta like cath them, like the bladder's too full, or there's like,
Neurogenic.
yeah, just weird stuff.
You know, and I've seen, that kind of explains things a little bit, because I've seen patients in there and their blood pressure go up, the heart rate go up, and like, we're doing all these things, but then all of a sudden it comes back down, it's just a reaction sometimes.
Or, yeah, like
Autonomic.
their toes were curled underneath them, and their
Yeah.
body didn't know how to react.
The whole body's connected at the end of the day. Everything in the body affects everything. It's crazy. Causes of hypomagnesis. I'm tired of saying the word. Hypomagnesemia. Alcoholism. Of all of them, alcohol, this is probably the number one that's affected by it. Alcohol can greatly reduce your magnesium level. You lose it to diarrhea, intestinal bypass surgeries, bulimia. What is that?
Throw up.
Laxative abuse, aggressive weight loss, get rid of too much magnesium that way. Excessive loss in urine. Here again, diuretics is always a possibility. It can make you have too much, too little of anything. Hereditary necrosis, acute tubular necrosis, associated with hyperaldosteronism, which gets rid of everything. Diabetic ketoacidosis, excessive lactation. Really? I think I heard that one. Hypermagnus, a lot of mag levels, or high level mag levels, are uncommon seen in patients suffering from renal failure. Like I said, it's always about the renal. Another cause is abuse of laxatives. Can be treated to help treat preeclampsia. So if you have one of the times I see them give this is, you ever seen they're in there trying to stop labor from happening? They'll give them mag sometimes to try to help that. And it helps to relax the smooth muscle as well. Any questions so far? And mainly for this stuff, what I want you to know is the normal range. Okay? There are some questions about some of the side effects of one of them, or two of them, if they're too bad or too much. I remember this guy. You're all probably too young. He was funny. If you have too much magnesium, hyperflexia, muscle weakness, hypotension, bradycardia, coma, and death. And that's kind of in the way that they go. As your magnesium level gets higher and higher, then you end up looking like that. So how many of you know study phosphorus? Yeah, nobody. Phosphorus, more than 80% of the total phosphorus is found in the bones. It's right there with the calcium. That's the reason whenever they break down the bones, you get so much phosphorus and calcium. So if you have too much of that hormone, osteoblast, you end up with really high levels of phosphorus and calcium. So major intracellular anion participating with metabolic processes. It plays a extracellular phosphate, so it acts as a buffer. Remember, this CO2 combined with this, it can pick up a hydrogen ion here and there. It's absorbed through the GI tract. It depends on vitamin D in order for that to happen. It's excreted through the kidneys and enhanced by parathyroid hormone. In other words, you'll end up absorbing more of it through the gut if that's released. So, speaking of that, what does phosphate do in the cell then? Without phosphorus in the cell, you can't rejuvenate, you can't make another cell because it's involved with the RNA, the DNA processes. The cell can't function properly. Phosphate, even though we don't talk about it a whole lot, without it, you can't do anything. I mean, it's very important in the body. It kind of, it's like hey, we're gonna do a reaction. Not without me. Hey, so it's kind of like, if you need energy, this bad boy needs to be there. Have you guys heard the word phosphorate? Phosphorate? Okay. Phosphorate means that it goes by and drops off an oxygen. Production of ATP. So, ATP, the process of letting, 3 sodiums out and 1 or 2 potassiums out. Well, they connect on, the phosphorus comes by and phosphorylates that. That gives it the energy to be able to do that. So it phosphorylates the ATP, allows it to contract and allow that process to happen. But without it, that process slows down. And guess what? If that don't happen, all the electrolytes get off, you don't process, you can't move like you're supposed to. It's actually important, even though you don't hear about it much. I guess it's usually within normals. You're gonna see what happens if it's not. It's part of the Paget's disease and all that. So in normal serum adults, the range is 2.7 to 4.5. Low phosphorus, it's primarily caused from decreased absorption, intracellular shifts, and increased extraction. So where's most of this found? Okay, that's true, but where's the other rest of it? Dadgum you, Kevin. Intracellular. Just want you to remember that, because that's one of the, remember phosphate, sulfate, those are the intracellular things, kind of keep it balanced, okay? Stress, severe stresses causing glucagon and cortisol release may be responsible for the low serum phosphorus seen in trauma patients. Okay. And if you have low phosphorus, this is some of the things that you'll see. Decreased contractility of muscles, obviously. Because remember, it has trouble doing the ATP process now, right? Cardiomyopathy. What does myopathy mean? There's some kind of disease process of messing up my heart or the muscle, myopathy, the muscle, cardiomyopathy, heart muscle. Hyporeflexia, hypoventilation. Severe cases can lead to rhabdomyosis. What's rhabdomyosis?
Something with muscle death, right?
Not something, that's exactly what it is. It can cause death of muscles and confusion, seizures, coma. Highlight, to make sure you know this. So, if somebody's phosphorus is real low, of the things you've seen up there, as a respiratory therapist specifically, what would be your major concern for the things?
Hypoventilation.
Hypoventilation, and what's the other thing you see? Not that one.
The contractility.
Which one?
First one.
Bingo. Highlight. I'm probably pretty sure you're gonna see, if you had a really low phosphorus, why would we care? Because it makes all your muscles weak, right? Including your diaphragm, cardiomyopathy. It can cause hypoventilation because of the diaphragm. Because what's the big boy on stage for breathing? Mr. Diaphragm. Mr. Diaphragm, Mr. Diaphragm, exactly. Make sure you remember that. So decreased absorption, malnutrition, alcohol abuse, vitamin D. Because remember, without vitamin D, I can't absorb the phosphorus, nor can I absorb the calcium. Vitamin D is really important, actually. Laxative abuse, antacid abuse, intracellular shift, increased secretion of it. Hyperparathyroidism, diuretics are always a possibility, hyperglycemia, alcohol abuse. There you go, that's what I was waiting to get down to. And this is what happens whenever you have way too much phosphorus in your blood. This guy is real. This guy is real. These are real people. So when you have way too much phosphorus in the blood, remember, what does it do? It starts creating bone, right? Well, there's so much phosphorus, it's creating bone so fast. Number one, it's not very, it breaks easy, it's fragile. And number two, it becomes almost, it's creating bone, but it's not really bone anymore. Look at this guy's legs. I remember this guy right here on the news. And you just look at him, you're like, he's alive? Poor fellow. But for some reason, several years ago, don't really see this anymore. All of a sudden it just stopped, they don't know why. Like you would see patients come in with these weird things like this right here. But several years ago, they don't really happen anymore. Yeah.
So was he born like that, or did that happen over time?
No, over time. Usually like Paget's disease, stuff like that, that happens in your younger years. I don't know what the treatment process is for Paget's disease, but I think once you got Paget, you got it for life. I don't think there is like a cure for it. I told you you'd be surprised when I got to the pictures. There you go. So is there any questions so far? Ones that I can answer, don't ask me ones that I can. There we go. And my God, you guys know lactate, right? And I think this is the last one. So an increase in lactate is caused by either increased production as a result of anaerobic metabolism or reduced degradation of lactate as a result of problems with the liver, because the liver gets rid of it, right? So if the liver can't get rid of it, it's gonna be elevated. And where does lactate come from?
The muscles.
Yep, specifically without oxygen, right? Energy without oxygen. Lactate is formed in ischemic cells as a result of anaerobic glycolysis, and indicates severity of shock. I would know lactate very well for the test. Okay, highlight all of lactate. Lactate is cleared by the liver. So, what's a normal lactate level, right? You guys remember that?
Say less than one.
Yeah, it's really low, right? So, part of with you coming in, the doctor saying, you know what, I think you're septic. This is one of the lab values the doctor will order. There's like 5 criteria you gotta meet. And if that's above 5, you meet that criteria.
I mean, infection too.
Infection will definitely make it rise. Infection will make it rise.
This was what was really high on that lady.
Sure was.
Yeah.
And remember, above 5 is considered positive.
Yeah.
So, yeah. You know, back in the old day, we'd get an ABG, the pH would be really low, but the bicarb would be low, the CO2 would be, but it's like the pH went too far. Like, why are you that far off? You know, it almost seems like the patient didn't and later when I started doing lactics with our blood gases, I was like, oh, and I see the correlation there. It just seems like, it's not, but it seems like it. It's also seen in patients with bowel ischemia. In rare cases, increased lactate has been associated with high doses of albuterol. We were talking about that. I've seen that a couple times. And you guys remember. So is this gonna make a high gap or no change in gap? Because we're going from an 8 to an 8, right? Very good. Normal values of lactate in adults is less than 2. Usually less than 1 for me. It's usually right around 0. I think so. All right. Is there any questions on any of this?